Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 453 of our pharmacotherapy series, which majors in lung cancer. The next case reads, MOW is a 63-year-old woman who presented to her primary doctor with a complaint of heartburn and pain in the right side of her upper abdomen. She also had a feeling of gas in the stomach. In addition, she noticed a 20-pound weight loss within 3 months, although she attributed this to changes in her diet. She was not complaining of any coughing. There was no shortness of breath. The evaluation with chest radiograph demonstrated the presence of a large mass in the right parihilar region with extension to the mediastinum and significant mediastinal adenopathy with narrowing of the trachea and its displacement to the left by the mass. The follow-up PET-CT scan confirmed presence of that large mass and no other areas of abnormality within the abdomen or pelvis. The patient also had a brain MRI that showed no evidence of metastatic disease. After that, the patient had a bronchoscopic evaluation and a biopsy of the mediastinal mass. Pathology came back positive for small cell lung carcinoma histology. Having disease only limited to the chest and mediastinum, the patient was diagnosed with limited stage small cell lung cancer. Peripheral blood chemistry, LDH, and counts were normal. What features of MOW's disease are suggestive for small cell lung cancer? MOW's chief complaints were heartburn and pain in the upper right side of her abdomen, not necessarily common symptoms of small cell lung cancer. Location of the tumor is a determining factor in specific symptoms that a patient can experience, and can serve as an indicator of the invasiveness of the disease. Although MOW did not complain of cough, her presentation is representative of patients diagnosed with this disease in that the tumor was centrally located with spread to the mediastinum. She also experienced weight loss and, although she attributed this to her diet, it is a symptom experienced by patients with rapidly growing disease and associated with appetite suppression. MOW did not experience all of the symptoms that are frequently found in patients. Fatigue, especially together with decreased physical activity, is a common complaint as well as hemoptysis. Owing to the central location of most of these tumors, approximately 10% of patients can experience superior vena cava syndrome, abbreviated as SVCS. This is a very serious complication and requires immediate medical attention as a result of the growing tumor impinging upon the superior vena cava. This can restrict blood return to the heart, resulting in head and facial swelling. My next question to you reads, what potential complications might patients such as MOW experience during the course of their disease? Patients with small cell lung cancer frequently experience paraneoplastic syndromes as a result of the disease, and these often differ from patients who have non-small cell lung cancer. For example, patients with non-small cell lung cancer have a higher tendency to develop hypertrophic pulmonary osteoarthropathy and hypercalcemia. On the other hand, patients with small cell lung cancer have higher incidence rates for hyponatremia, Cushing syndrome, and neurologic paraneoplastic syndrome. The serum concentrations of antidiuretic hormone are often elevated in small cell lung cancer, but few of these cases fulfill the criteria for SIADH and are mostly asymptomatic. In some cases, ectopic production of atrial natriuretic factor contributes to the disorder in sodium homeostasis. Because small cell lung cancer is usually responsive to cytotoxic agents, the treatment of choice for hyponatremia is chemotherapy. If further management is needed, i.e., if the cancer is non-responsive to chemotherapy or symptomatic, fluid restriction, intravenous hypertonic saline, and treatment with demeclocycline are options, depending on severity. The serum concentrations of adrenocorticotropic hormone are elevated in approximately half of patients with lung cancer, but Cushing syndrome develops in only 5% of those with small cell lung cancer. Low serum sodium and Cushing syndrome are both poor prognostic indicators for the disease. Unlike MOW, most patients already have metastatic disease at diagnosis, and the most common sites include bone, liver, adrenal glands, and brain. Patients with hepatic and adrenal lesions do not usually experience symptoms, even if they have elevations of bilirubin, alkaline phosphatase, or hepatic transaminases. In contrast, brain metastases are symptomatic in more than 90% of cases, and patients can often present with central nervous system complications, e.g., seizures, as the first sign of the disease. MOW reads about various treatments for her disease online. So my next question to you reads, what is the utility for each of the three treatment modalities, i.e., surgery, radiation, and chemotherapy, for the treatment of her disease? We will discuss treatment modalities for small cell lung cancer. Surgery. As mentioned earlier, surgery has a very limited role as part of the treatment for patients with small cell lung cancer. In general, patients with tumors larger than 3 to 7 centimeters and presence of any disease in the lymph nodes or distant metastases do not benefit from surgery. The percentage of patients who fit this category is less than 5%. If surgery is chosen, the procedure usually includes lobectomy with mediastinal nodal dissection and sampling. Thereafter, patients would receive adjuvant radiation and chemotherapy and then prophylactic cranial irradiation as described in the subsequent sections. Regarding radiation, small cell lung cancer is responsive to radiation therapy. Therefore, it is useful in treating patients with limited stage disease. These treatments are usually given as fractionated doses over the course of 3 to 7 weeks, and total dosage targets range between 45 and 70 Gray, abbreviated as GY. The optimal dose and frequency of administration of radiation is still under investigation. Three-dimensional conformal radiation, intensity-modulated radiation therapy, is the preferred method, and the radiation is delivered from an external source concurrently with multidimensional imaging to assure tumor movement of less than 1 centimeter is achievable. Movement as a result of breathing during the procedure. In addition to their cytotoxic effects, many chemotherapeutic agents also sensitize tumors to radiation. Hence, Radiotherapy should start concurrently with chemotherapy, usually at the first or second cycle. Due to the high incidence of metastases to the brain, i.e., greater than 50% of patients with small cell lung cancer, prophylactic cranial irradiation consisting of 25 to 30 GY given for 10 to 15 fractions is the standard of treatment for patients with limited stage and extensive stage disease after completion of initial chemotherapy or chemoradiation and minimal residual systemic disease. And now let's consider chemotherapy. The proliferative indices for small cell lung cancer cells are high and early metastatic spread is common. Therefore, systemic chemotherapy is the treatment of choice for its utility in treating metastases and because it is effective for tumor cells progressing through the cell cycle. In general, most of the regimens are platinum-based combinations with etoposide or, less commonly, irinotecan, the latter proven to be efficacious in Japanese patients. As outlined in if a tumor response is observed, the benefit is usually seen early in the treatment course. Prolongation of treatment beyond 6 cycles is usually not recommended for this disease because the maximum effect of the treatment is achieved in this time frame. Further, toxicity after treatment with these agents accumulates and diminishes the overall benefit to the patient beyond 6 courses. Hence, treatment is usually stopped after 4 to 6 cycles and the patient is closely monitored for recurrence of the disease. As mentioned previously, small cell lung cancer has a very high rate of recurrence. Therefore, second-line therapy is usually implemented. Several choices of agents are available and the selection is dependent on the overall condition of the patient, e.g., performance status, toxicity from previous regimen, and the length of time after the first-line regimen was completed. Many of these agents are given as single-agent therapy except for the CAV regimen. In general, a recurrence that occurs within 6 months of treatment with first-line therapy is considered resistant and other agents are selected. If recurrence occurs after 6 months, then the same agents used for the first-line regimen may be used again. To date, no targeted agents are approved for use in treating small cell lung cancer. In conclusion, MOW's disease would not be a good candidate for surgical removal because there is lack of proven benefit. Small cell lung tumor cells proliferate rapidly. Therefore, they are usually responsive to chemotherapy and radiation treatment. This systemic therapy would also be favored because the tumor tends to metastasize quickly and it provides a way to eradicate disease that may have spread. MOW begins therapy with intravenous cisplatin on day 1 combined with etoposide on days 1 to 3 given in a 21-day cycle. 4 to 6 cycles are planned, and she will also receive concurrent radiation. For MOW, what is the goal of therapy? My next questions to you read: what objective baseline data should be acquired prior to starting treatment? What monitoring parameters should be utilized? We will discuss treatment with chemotherapy and radiation. The goal of therapy for a patient with limited stage disease such as MOW would be to increase overall survival and achieve a potential cure. In patients with limited stage disease, response rates of 70% to 90% are expected after a regimen such as the one MOW is receiving, whereas response rates of 60% to 70% are expected for patients with extensive stage disease. If MOW had been diagnosed with extensive stage disease, then the goals would have been to increase overall survival and for palliation of symptoms. Given the complications that can arise as a result of small cell lung cancer, treatment could be used to minimize these adverse events. For example, radiotherapy is often used in treating patients with SVCS, because it would reduce tumor size and enable resumption of more normal blood flow. Therefore, if a patient has acceptable performance status, e.g., 0 to 2, and minimal to no comorbidities, then treatment such as the one that MOW is receiving is the best course of action. A treatment regimen such as cisplatin and etoposide plus radiation is tolerated by most patients, especially because the number of cycles is usually limited to 6. However, administration of these cytotoxic agents is associated with several adverse effects, some of which can be life-threatening. Hence, the clinician is expected to anticipate these events and plan treatment accordingly to minimize complications. The patient is receiving cisplatin, which causes several different adverse effects such as renal insufficiency, sensory neuropathy, ototoxicity, and is considered highly emetogenic. Hydration and diuresis are required with cisplatin doses greater than 40 mg per meter squared to maintain a urine output of 100 to 150 ml per hour before administration of the drug. The intravenous fluids are often supplemented with potassium and magnesium to counteract electrolyte wasting from cisplatin. Monitoring of serum creatinine, electrolytes including magnesium and calcium, is performed usually before each infusion of chemotherapeutics. An appropriate antiemetic regimen must be implemented to prevent both acute and delayed nausea and vomiting. For etoposide, neutropenia is usually the dose-limiting toxicity. Therefore, monitoring of absolute neutrophil count, abbreviated as ANC, is important and, if the counts do not recover before the next dose is due, then delays in treatment or dosage reductions occur. In Phase 3 clinical trials for this regimen, Grade 4 leukopenia occurred in approximately 35% to 40% of patients, and any grade fever and infection in greater than 20%. Therefore, consideration must be given toward the use of colony-stimulating factors to manage this latter event, usually after radiation is completed. In conclusion, the goal of MOW's therapy is a potential cure. Hydration with fluids supplemented with potassium and magnesium must be initiated prior to cisplatin therapy to prevent cisplatin-induced renal toxicity. During therapy, clinicians must observe for decreased absolute neutrophil count due to etoposide and may need to implement delays in therapy or use of a colony-stimulating factor, e.g., granulocyte colony-stimulating factor, filgrastim. Supportive care such as antiemetics during therapy to prevent or manage cisplatin-associated acute and delayed phase nausea and vomiting will also be essential. MOW tolerated therapy very well with mild esophagitis and cough during treatment. She did not experience any vomiting due to aggressive antiemetic use, nor did she exhibit any neuropathy or hearing loss. So my next question to you reads: what adverse conditions that MOW experienced are associated with her treatment? Both esophagitis and cough are likely attributable to radiation effects. If esophagitis worsens to grade 3 or more, patients can lose the ability to swallow and may require a feeding tube. During therapy, cough can develop and patients may become concerned that it is a sign of worsening disease. Radiation-induced pneumonitis, acute, in first 3 months, and chronic, that is after 4 to 12 months, can be a frequent cause of the new onset of cough, which can be ameliorated with corticosteroid treatment. After 2 cycles of chemotherapy with concurrent radiotherapy, ACT scan indicates a partial response. Therefore, an additional 4 cycles of cisplatin and etoposide were planned. So my next question to you reads: how is the course of MOW's disease likely to proceed? The chances for long-term survival greater than 5 years are very low, even for the patient with no other comorbidities and limited stage disease such as MOW. At the completion of chemotherapy, MOW should be offered therapy with prophylactic cranial irradiation, because brain metastases occur in greater than 50% of patients with small cell lung cancer. Prophylactic cranial irradiation not only reduces the incidence of metastatic disease, but also increases overall survival. Within a year of completing therapy, most patients experience progressive or relapsed disease. The duration of the remission is the single largest predictor of outcome, and patients are classified as having either sensitive or refractory disease, depending on length of this duration. Approximately half of those tumors that are deemed sensitive in this setting will respond to second-line therapy. Therefore, most small-cell lung cancer tumors become resistant to therapy either during first-line or salvage therapy. Patients can also exhibit second primary tumors, especially non-small cell lung cancer, during the course of the disease. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 454.